So last week I got back on the week ago Sunday. I was in Belgium, and we launched the Euthanasia Prevention Coalition Europe. And the importance of it was that other than England and Scotland, so the UK, there were no groups organized to oppose euthanasia or assisted suicide in Europe, and yet there's this big battle going on to push it in Europe. So in February of last year, we had a meeting of representatives from 10 countries at the time, and now we've got representatives from 12, but it's moving on. And the idea was that we need each other, we need to work together to oppose euthanasia and assisted suicide, and now we have an organization in place, we have a director, we have the whole thing rolling. Very exciting. So I debated this guy from Belgium, and he's a famous promoter of euthanasia. He's gone all over the place. He's been to Canada, he's been to Australia, you name it, promoting euthanasia. And this is what he does in his retired time. He goes around promoting euthanasia. His name is Jan Bernheim. And so at the end of the talk, when I went through all my material, well, we had a debate, but it really wasn't a debate. We each gave a talk, and then we took questions and answers. He says, I admit there are serious problems with the euthanasia law in Belgium. So if you go to my blog, which is alexschadenberg.blogspot.com, I write about this and I say, well, that's cold comfort for the dead, you know, because what is the result of euthanasia? Even when they do it, you know, it is death. You know, you're dead. You can't return that. You can't change it. It is done. So I think some of the definitions have been handled already for you. Now, is this going to go? Oh, there it goes. So we're going to discuss what euthanasia is, what it isn't. I'm going to go through a lot of information with you. I move fairly quickly, so you can read the PowerPoint, and you can buy the video later and watch it again. So euthanasia is both an action and omission of an action. But what's important, which was said earlier, is it's direct, it's intentional. So these are intentional decisions to cause death. Okay? So it's not about accidental decisions. It's not about, you know, other things that might have happened. It's intentionally to cause death, and death is caused by that action or omission, usually done by lethal injection. That's euthanasia. Now I'm going to get into assisted suicide in a minute. Very similar but different. It's a type of homicide, murder. When somebody intentionally causes your death as murder, the only difference here, they claim it's done for reasons of suffering, right? That's what they claim. Often it's called mercy killing. So what is it not? Well, remember, I'm going to be very clear with my definitions, because today's actually about some of these very points. It's not about withholding or withdrawing medical treatment, especially when it's futile, burdensome, extraordinary. Now remember, I'm talking about treatment. I'm not talking about care. It's very important to make the clear distinction between treatment and care, because treatment is always an option, which is what you have to remember. When you're needing treatment, you always have the option of saying no. Whether you should or not is not the issue. You have the option. In the case of care, we're obligated to provide you care. Care, basic care. I'll get into that in 1 second. It's not about the proper use of large doses of analgesics. Now, this is going to be somewhat about this, because are the analgesics being abused? At times. At times. I'm not saying all. The answer is yes. So if you intentionally abuse the use of morphine, meaning you're intentionally causing death with it, now I'm going to say something else. It's not that easy to do. The difference between the proper use of an analgesic and the killing use of an analgesic is actually quite distinct. So if they actually were in hospitals, etc., medical institutions trying to control this, they could do so. They could do so. Clearly the intention can be seen by how a physician is prescribing. Okay? It's not about the proper use of sedating a person. Now you may say, well, you know, what do you mean? What are we talking about sedation? Well, often they will sedate somebody. Let's say somebody's in intractable pain, and we've tried whatever we can to reduce that pain to an acceptable level. If it cannot be done acceptably, meaning the person is suffering, really suffering, it's morally acceptable to sedate a person, but not to kill them. Now, of course, if you sedate a person, you can also then do what? You can also withdraw hydration and nutrition and dehydrate them to death, which is usually what is done. In the case of sedating a person, though, there's the other point. Why are we sedating a person? Some people who might want euthanasia would be sedated. And then they'd say, well, it's not legal, so we'll sedate the person, and then we'll provide them no care whatsoever, no food, no fluids, no anything, and of course they will die soon after. That would be euthanasia. So the proper use of pain-killing drugs we don't want to discourage. Of course, the abuse is the problem, right? That is the problem. Euthanasia by omission. Well, this was dealt with a minute ago. The intentional dehydration of a person who is not otherwise dying. So I make the clear distinction between a dying person and a not otherwise dying person. And this is important because when somebody is dying, and it was mentioned in the last presentation, when someone is dying, often they might have a situation where they're just simply not assimilating. That was mentioned. Or they're so near to death that their body is breaking down that sometimes there's harmful effects of the food and the fluids. But that's someone who's nearing death and dying. But usually, not usually, often when somebody, let's say, had a head injury. So let's say somebody has had a head injury. Or let's say they have dementia, but they're physically healthy. They're physically healthy, but they have dementia. And so we have a case like this right now in British Columbia, the spoon feeding case. Margaret Bentley is being fed by spoon. She swallows effectively, so she's not like she can't swallow anymore. There's not harm to feeding her. They feed her by spoon, and she opens her mouth and she eats. She's not being restrained. And nothing like that is being done. She's just being fed. And the family says, but she has a power of attorney document that says that in such and such a circumstance, she didn't want any extraordinary treatment. She only wanted comfort care, etc. And she didn't want food and fluids by artificial means, and they want then the spoon feeding to be defined as medical treatment so they can withdraw it. That would be euthanasia. So in the same case here with withdrawing fluids, in the case of Terry Schiavo, which is the case most of us remember so well, Terry Schiavo was not dying. If she were dying, then there could have been medical treatment questions, but she was not dying. And so in order to cause her death, they dehydrated her to death. So let's make clear distinctions. We're not talking about dying people. We're talking about people who are not otherwise dying being dehydrated to death. Let's be very clear about this. Why am I saying about always being clear? The other side wants you to be confused. The other side wins when you're confused. The best way for us to win is for you to be clear. We win when we're clear. So let's be very clear about this. Okay? This is different from accepting the limits of life. Okay, because accepting the limits of life is sometimes necessary with food and fluids when someone is actually dying and nearing death. I get calls all the time from people, and sometimes they are real concerns, and sometimes these people have confusion. Like sometimes someone's calling and their family member's actually so near to death that I say to them, well, you know, sadly your father's dying, and really there's not much we can do. But often I get calls and clearly this person is not dying, and the doctors are pressuring for death to occur. So we must make these distinctions. So we need to properly also define assisted suicide, especially in the United States where this is being promoted. The other side likes to call it aid in dying, which is a euphemism to make you feel better, right? Aid in dying. Well, what is aid in dying? Well, aid in dying could be anything, really. Aid in dying could be good palliative care. The other thing about aid in dying is it could be euthanasia. You know, the euthanasia lobby has no problem with, mucking everything into one in order for them to say to you, well, we do it already, so we might as well just legalize it all and regulate it, right? They like to just put everything into one terminology. Assisted suicide is not aid in dying. What it is it's when one person is directly and intentionally involved with killing the other person. So it's different than euthanasia. So euthanasia is when I lethally inject you. I kill you. Assisted suicide is when I give you a lethal dose and you kill yourself. Now, they're two birds of a feather. They do flock together, okay? And the fact of it is the end result is the same. So what is the law saying? The law is not saying that you can't kill yourself. And I'm not telling you to go out and kill yourself. Okay? The law is not saying you can't kill yourself. The law is saying I can't kill you, and I can't be involved with you, with your death. I can't be directly, intentionally involved with that. And that's good. You need sometimes to be protected, maybe not from me, but from people like me. You need to be protected. The law protects you. So when they try and legalize assisted suicide, what are they doing? They're taking away your protection in law. That's what they're doing. The question earlier about autonomy, this is not about autonomy. That's a lie. They're selling you a lie. It's not about autonomy because you're not killing yourself. Somebody else is directly and intentionally involved. So in the case of assisted suicide, which is what they keep talking about in the United States, somebody is directly and intentionally involved with you doing this, with the decision, the encouraging you to do it, the providing you the means. It's not about autonomy. Autonomy is what I do to myself. Okay? These are not clear autonomous decisions. And we have to understand that the other side likes to sell it like it's just another form of suicide, and it's not. It's different. We also need to be clear about the question of killing and letting die, because this is a fundamental question here. What does the other side say? We do it all the time already. Now, in some cases, they are abusing analgesics. That's correct. And they are doing it, but that should be stopped. But their argument is, we withdraw treatment all the time. We do these things all the time. We might, and even the proper use of morphine, they'll say that might lead to death. We're doing this all the time already. Therefore, isn't it the same as to kill as to let die? And the answer to that is clearly different. And I think the answer you got in the last presentation was right on the money. There's a clear difference between someone killing you and letting you die. And this is an important distinction, because if there is no difference, then we might as well just legalize it all and regulate it. Right? Because we're just talking about things that really in the end make no difference. But they are clearly different. Now I'm going to give you a very hard circumstance, a very hard example, and that is the ventilator. That's probably one of the toughest examples we can deal with, okay? Is it right to withdraw a ventilator? And the answer is, sometimes it is, sometimes it isn't. Right? Sometimes someone is actually nearing death, and sometimes they're not nearing death, right? Sometimes, if someone might be a person with a disability, they're dependent on the ventilator. They're very, very healthy. The ventilator is doing a very great benefit to them. Sometimes they are really dying. Okay, but when you withdraw a ventilator, is that the same as euthanasia? It's a very tough question. Let's think this one through. What happens if you give me a lethal injection? I'm dead. And I'm actually good and dead. Now you have to understand here how they do it. They don't do it, like people have this understanding, oh, they're just giving you an overdose. No. They're giving you a specific drug dose of a specific nature to kill you. Okay, so they're giving you a muscle relaxant first, and then they're giving you a barbiturate, and they're doing it in such a way to kill you. You're dead, okay? And in fact, they've really refined the methods, okay? Because in the early days in the Netherlands, there were a lot of problems. They gave someone euthanasia, they didn't die. They've really refined the methods. They're quite slick at it now, okay? What happens when you withdraw a ventilator? And I'm telling you, you should withdraw the ventilator. I'm saying, what happens when you withdraw a ventilator? Do they always die? No, they don't always die. So in real life, I know that there's a clear distinction and difference between withdrawing that treatment and actually lethally killing you. Now, I can intentionally withdraw a ventilator with the intention of killing you too, right? I can abuse that. But nonetheless, there is a difference. Even in a hard moral circumstance, it's very hard to go through, you can see that there's a clear difference between killing and letting die. Okay, what's happening in Quebec? I'm just going to mention this to you. Quebec has gone crazy. That shouldn't surprise any of you. That's on tape. That's fine. They know it already. So in Quebec, so how it works in Canada is euthanasia, assisted suicide are federal criminal code questions. The criminal code in Canada is dealt with federally, whereas in the United States it's a state issue, right? So in Canada, the federal criminal code clearly has euthanasia and assisted suicide as completely illegal. In fact, the law is perfect the way it's written. So in Quebec, they've decided, well, we're going to define euthanasia as medical treatment. So if we define it as medical treatment, because in Canada, healthcare is provincial. So they're going to call it medical treatment. And so what they've said, oh, I got rid of it. Anyway, by defining it as medical treatment, then they're going to legalize euthanasia, they're saying. Now, this is unconstitutional. Very unconstitutional, but that's what's happening in Canada. That's what I'm facing right now. So in Oregon, they legalized assisted suicide in 1997 through a plebiscite. It came into place in 1998. You had assisted suicide legalized by a voter initiative also in Washington State. in 2008, became into place in March of 2009. The Baxter decision in Montana didn't actually legalize assisted suicide, but it did create an exception in law for physicians. So it is a serious problem. And then there was the voter initiative in Massachusetts in 2012 that was defeated, thank God. And recently Vermont legalized assisted suicide. So this is your sort of political playing field right now. Right now they're pushing very hard in New Jersey. New Jersey is the big state on the ground right now. And there's a court case in Minnesota right now around the question of assisted suicide. I'm assuming that this state of California is also on their list. The only difficulty with the other side is the other side's got a ton of money, but they like to focus on one state at a time because then they can pour all their money into that one spot. And California is a big state to fight a campaign over. So it's, I think they might wait, or they may not. It all depends what they're going on with. But New Jersey is their next big goal in the United States. Oh, yeah. I put it in the wrong spot. That's why. So anyway, what they're doing in Quebec, back to Quebec. I made an adjustment. Anyway, the Belgian euthanasia law is what they're actually trying to be identical to. So a little bit of information for you. In the Netherlands, they legalized euthanasia by creating an exception to the criminal code. So in the Netherlands, euthanasia is then the exception to homicide. And as long as you follow these principles, meaning you have a second doctor agreeing, the person is, quote, quote, suffering, etc., then it can be done. Belgium did it a little different. They used similar definitions, but what they did is they called it medical treatment. And they administer it through the palliative care system. As sad and as crazy as that is, that's what they're doing. So that's why Quebec is following the whole thing. They say it's about terminal illness, but it's not. It's not. They define it as suffering physically or psychologically with an incurable serious illness. Now, is there anybody in the room with an incurable serious illness? There must be a couple of people in the room. Yeah, there we go. Several of you actually have an incurable serious illness. And yet, that doesn't mean you're terminally ill, okay? Also, they said they're going to create a right to palliative care. But what they've done is they've defined euthanasia in Quebec as a part of palliative care, which is the same as Belgium. And so what they're actually saying is they're going to create a right to euthanasia. Now, this might not make you too upset because you're not Canadian, but the fact is there's a big difference between legalizing something and then saying you have a right to it. There's a nodding heads. They recognize exactly what I'm talking about. You can't take away someone's rights, right? So if you legalize something and then say you have a right to it, then the doctors are going to be having a right to they have to do it, right? So let's go through these cases. How many of you saw this case of Mark and Eddie in Belgium? There's a few hands going up. So most of you did not see this case before, where these men were born deaf. They were twins born deaf. They lived their whole life together, and they had macular degeneration. They were going blind. They weren't blind yet, but they were going blind. They asked for euthanasia. Their doctor said no. Okay? They went to a couple of other doctors. They said no. So then they went to this one doctor who's really known for euthanasia, and they said yes. Now you have to understand how it works in Belgium. In Belgium, if you're not terminally ill, and these two men were not terminally ill, you need two doctors saying yes, and then a third has to be a psychiatrist. But you see, the interesting thing is the euthanasia guru doctors, they know the psychiatrist who will say yes, right? So it's not like you're getting referred to the doctor who's going to say no. They get referred to the psychiatrist who says yes. So they go to him, they said yes, and they died by euthanasia because of psychological suffering. They were afraid of becoming dependent on others, and they said it would be psychological suffering. So think about this. Well, in October, there was the first case ever of a woman who was going blind who was euthanized. Now, she was not sick. She had no physical illnesses. She was not physically suffering, but she had a neat freak problem. Now, how many of you are Dutch? Well, you guys understand, okay? She had a problem. She said that she was obsessed with cleanliness, and she said that she couldn't live without being able to clean the spots off her clothes. She said it would be too great a psychological suffering to go blind. Now, how many of you saw that case? You guys have to go to my blog. You'll see all these things, okay? You'll know these cases. Psychological suffering, she's going blind. Now, let me ask you another question. My friend Amy Hasbrook, She's blind since birth. She runs a disability group in Quebec. She's actually an American from Massachusetts, but she married this guy from Quebec. So anyway, so she's one of yours, but she lives in Canada. Now, does this also affect our attitudes towards people who are blind? If euthanasia is an acceptable reason for blindness, well, what about people who are blind? Do these things translate into our attitudes towards others? Well, without a question, they do. This became a news item in the Netherlands because that was the very first case. So let's make you understand this. They don't have these cases in order to protect the vulnerable. These cases are done in order to extend the law. So every time you hear of one of these cases in Belgium or the Netherlands, it's to make it acceptable. This was promoted because now it becomes, because nothing was done about it, so now it's okay to have euthanasia for people going blind. Because it was done, it's accepted, it's fine. Now they're saying to all the other doctors, go ahead, it's fine, do it. So they're extending the limits of the law this way. That's how it works. Well, what about this case? This case is absolutely insane. Anne was 44 years old, had anorexia nervosa. She had had it for many, many years. She had had lots of relapses, a lot of difficulties with it. She went to this man, who's a psychiatrist, very well-known psychiatrist in Belgium, as a leader in the issue of anorexia. He established a sexual relationship with her. She felt like she was being sexually used. She put in a serious complaint about it. She claimed that he had also been having sexual relations with other patients too. I don't know about this guy. Anyway, Anne was so upset by how she was treated and how the reaction was to her complaint that she said that the psychological pain was unbearable. She died by euthanasia. Think about this. Dr. Van der Eyck is seeing patients again. And this is the key. Dr. Tom Mortier. He's a chemistry professor in Belgium. I just met him the week before. He's been up to Quebec also speaking. Tom, his mother had gone through chronic depression throughout her life. His father committed suicide when Tom was 5. His mother was a teacher. When she retired, he sent this picture of her because she went traveling all over the place. She loved to travel when she was retired. But she had a relationship with a man that was long-term. It broke up, and she went into deep depression. She broke off all relations with her family members, her children, etc. And he got a call on April 20th telling him that the day before his mother died by euthanasia, psychological suffering. Now, I've gotten to know Tom, and if you go to my blog, you'll see that I've got a recent article he wrote, and I just put it up the other day. And it was him and I who did it together, so in case you've seen it all over the place, like National Right to Life, those other places, it originated with Tom and I. Anyway, the fact is that Tom has now known that her long-term psychiatrist said no. She went to another psychiatrist, and he said no. But of course, the euthanasia gurus, they know who to go to. So they sent her to a psychiatrist who then said yes. So remember how the law works. It's the same in Oregon. I'm going to get into it too. It doesn't matter how many black balls were received. All you need is one green light. Okay? It's not about protecting people. These laws are not designed to protect you. These laws are designed to protect the doctors. They're designed to make it happen. That's how these laws are designed. Let's be very clear. And let's talk about Dr. Charles Bentz in Oregon. How many people have heard of him? He's a great man. A few hands have gone up. He's a great man. He's been involved with Physicians for Compassionate Care, a group that was founded in Oregon to oppose assisted suicide. Dr. Bentz had a 76-year-old patient. This was a long-term patient, not a short-term patient, so he had known this patient for many years. This patient he had diagnosed with cancer, and it was a significant case of cancer. It was not a diagnosis with a lot of hope. Nonetheless, Dr. Bentz was very clear that his patient was very depressed about this. He had referred his patient then to a cancer specialist, and the cancer specialist then, after seeing his patient, calls him up for the second opinion. So obviously this is not a regular euthanasia doctor, because they're assisted suicide doctors, because the regular guys, they know who to call. They don't call people like Dr. Bentz asking for the second opinion. Okay? Bentz says, no, my patient is depressed. my patient does not qualify for assisted suicide. So what does the Oregon law say? The Oregon law says that if there is signs of depression or mental illness, that they must be sent for a psychiatric or psychological analysis. But in fact, that's rarely done, rarely done. So what happened is 15 days later, Dr. Bentz learns that his patient died by assisted suicide. So the point was, here you have the primary care family physician who knows him saying, no, my patient does not qualify. It didn't matter. This doctor just talks to another doctor, gets a yes, and it's done. Was that patient protected? So here's the point they're going to get to you at. Oh, maybe I'll use the next one first. Now we'll go back here first. They're going to tell you that we want to legalize assisted suicide in California is what they're going to say to you. And they're going to say it's you who are imposing your moral values upon them because they want assisted suicide and you don't. And they're going to say to you that we're going to legalize this and we're going to have a law that will protect you. They're going to say we're going to have safeguards. Do the safeguards protect you? No. Dr. Bentz couldn't protect his own patient. The law is not designed to protect you. So what's your comeback? This is not safe. This is not safe. You're, in fact, imposing your morality on me. Right? This will not protect me. And the other point is, well, I'll get to it later. Barbara Wagner. Now, this is talking about medical care questions. There's two issues here. The first we're not going to deal with today because it could be a whole other conference, and that's on the question of whether treatment plans should pay for everything or not. I'll tell you in Canada, where we have a one-payer system, the medical treatment does not pay for everything. Okay? If the doctor says we have to give you this treatment, a lot of treatments are not listed. So therefore the doctor will never offer it to you because it's simply not listed. Okay? So what do people do in Ontario when it's not listed? They go to Buffalo. Okay? Okay, so Barbara Wagner had recurrent lung cancer. So this is not good. She had lung cancer. She went into remission. It recurred. Her prognosis was not good. So nobody's arguing here that Barbara Wagner would have survived if she had this treatment. In fact, she did get the treatment in the end. The fact is what was the state of Oregon doing, saying to her when they denied her medical treatment, you can have assisted suicide? Because this is all supposed to be about choice. Choice and autonomy. It's my freedom of choice. If it's my freedom of choice, what's the state doing offering it? What's the state doing getting involved in the promotion and the pressure to die by assisted suicide? To say to someone will pay for you to die but not pay for you to live is cruel. Barbara Wagner is right. So the other question of whether or not states should pay for all medical treatment, that's the next conference on another weekend. Because the other side wrote a letter. What's her name? Wrote a letter, Barbara Coombs-Lee. Coombs-Lee, who's the big leader of Compassionate Choices, she wrote a letter saying it was unacceptable that Wagner would think that such expensive medical treatment should be offered to her. That wasn't the question. That wasn't the question. And even then, she's supposed to be for patient choice. Gosh, if the Compassionate Choice is all for patient choice, they should have said, well, Wagner should have had this choice, but anyway, getting back to it. Jeanette Hall. Jeanette Hall is actually alive today because it isn't completely about autonomy. It's because her doctor didn't agree with assisted suicide. She, in the year 2000, had voted in 1997, she voted in favor of assisted suicide. She was given a prognosis of 6 months to a year to live with cancer. She wanted assisted suicide. She just wanted to know how to get it. That's all she was seeking. How do I get this? And her doctor was saying, well, why don't we try some treatment? So she tried a little bit of treatment. She then told her doctor that her daughter was getting married, and then he convinced her to really accept treatment. She's alive today. This is a letter from 2012 that she wrote. She was just in Quebec recently talking to the members of the Quebec legislature. She says, it is now 12 years later. If my doctor believed in assisted suicide, I would be dead. I thank him and all the doctors for helping me choose life with dignity. And this is the point. The point of it is this is about subtle pressure. This is about people who sometimes are going through depression. They're making decisions that otherwise they need to be protected from. Did the law protect her? No. In this case, the doctor did. Well, we had this case in Canada of Dr. Lowe. Now, Dr. Lowe was quite a famous doctor for two reasons. One, we had a SARS crisis in 2003 in Toronto, and he was the epidemiologist who sort of walked the people through the SARS crisis, and he was on the news every night. He became quite famous. But he also was married to the former medical health consultant for CBC, which is our public broadcaster. So, you know, that made him also famous because he had access to significant media when he wanted it. Anyway, he said, so he died recently, and there was this big push in Canada. Some of you might have seen it. Did anybody see it all? No, so this is a fresh audience with this one. He was dying of cancer, and he said that if you were to live in my body for 24 hours, you would change your mind on assisted suicide. And this video was done very well. They had him looking really, really bad, and he was quite a good orator. He's quite talented, and he was 8 days from death. Anyway, this friend of mine, Steve Passmore, responded to it. Someone's phone is singing. So what does Steve Passmore say? Because remember, he said that if you were to live in my body for 24 hours, you would change your mind on assisted suicide. He says, I was born with cerebral palsy, and I've lived all my life with pain. My condition is deteriorating. I now have scoliosis, which is giving me further pain, and my prognosis is living with a wheelchair. So right now he has canes. I have a hernia, but because it isn't permanent, I don't qualify to receive help to clean my apartment. Living with a disability also means that I've experienced discrimination. Now here's his point right here. Most people with disabilities generally live with pain, suffering, and social isolation. He says, legalizing euthanasia or assisted suicide is an abandonment of me as a person. That society would rather help me die than help me live. Because that's what society is saying when they legalize. You'd rather help me die than help me live. The concept of euthanasia creates great fear for me. It's an important point. I have only one life to live. I choose to live. Society needs to ensure life with dignity, not death with dignity. So what are we about? We're about caring for the other. I think Steve hit it right on. The money. This was published in our National Post. And it's the proper response. So now I'm going to go through some stats with you. So we had a court case you might have heard of in British Columbia. It was the Carter case. And Justice Smith, who heard the case, she decided that our law on assisted suicide in Canada was unconstitutional. And she said it was unconstitutional because it was an inequality, because people with disabilities were incapable of killing themselves, whereas able-bodied people could kill themselves. You shouldn't laugh. She took it seriously. She also said that we needed to legalize euthanasia, a limited form of it, because some people with disabilities couldn't even die by assisted suicide because they couldn't actually do it themselves, right? They would need someone to actually lethally inject them. She also ordered the federal government to legalize this by June 15th of this year. Now the federal government, as you would realize, appealed the decision, right? And she gave the woman who was the main plaintiff, Gloria Taylor, a constitutional exemption to die. Okay? This is important, okay? So here you have in Canada this Royal Society of Canada report that came out. You have the Justice Smith decision. You had the Dying with Dignity report in the UK. And you also in Quebec had the Quebec Government Select Committee on Dying with Dignity. Now they all say the same thing. And you're going to see this stuff thrown at you. They all said this, that the euthanasia assisted suicide, in the US they're going to say assisted suicide should be legal. They all say that in jurisdictions where it's legal, there's no adverse effects on vulnerable groups. That's what they say. They say that there's no proof that a slippery slope has or will occur. They all say the same thing. All those studies. So let's look at this. Let's look at this. So what do we have here? I have a study here that was published in the Canadian Medical Association Journal. It was a study done in Flanders, Belgium. And I'm going to get a bit of water. So what they did is they looked at all the death certificates from 4 months in Flanders, Belgium. In the 4-month period, there was 6,927 deaths in Flanders, Belgium. They sent out a 5-page questionnaire to all the primary physicians who dealt with those 6,927 deaths, and they received 3,623 usable responses. So what's the importance of that? There's a lot of data here, an awful lot of data. This is a good study. What did they find? This is Belgium, where euthanasia was legalized in 2002. They found that there had been 137 euthanasia deaths, 5 assisted deaths, suicide deaths, and 66 assisted deaths without explicit request. 66. 32%. When I brought this up with Bernheim, now he knows this study well. Okay, he knew this study very well. What did he say? He said, yes, but the same thing is happening where it's illegal. That was his response. Euthanasia deaths occurring without explicit request. Who were they? Who were these people? Well, 91% of the time they were either comatose or dementia. Who were they? They were what we call, sadly call, bed blockers. Have you heard that term before? You've heard that term, right? Well, that's a term used in Europe all the time. Bed blockers. Bed blockers. They were bed blockers, meaning these are people who are in pretty rough shape, but they're not dying. And they're not dying quickly. And we need their beds. They didn't ask for it, but they got it. 17% of the time, the physician thought it was in the best interest of the patient. That's why it was done. 8% of the time, the physician thought a discussion on this issue would have been harmful. We won't discuss it. We'll just do it. Now, here's the other thing. In Belgium, doctors can only do it, it says. It's supposed to be a safeguard. Nurses are often involved in these deaths, doing it. Okay? Let's go further. The study said the use of life-ending drugs without an explicit patient request involved patients with diseases other than cancer, which have an unpredictable end-of-life trajectory. So what the study is saying is, well, some of these people might have been dying soon, that's correct, but a lot of them, we don't know how long they would have lived. Right? We don't know. We simply can't answer that. Our finding that the use of life-ending drugs without explicit request occurred predominantly in the hospital and among patients 80 years or older who are mostly in coma or in dementia. And what did the study say? Fits the description of a vulnerable patient group at risk of life ending without request. And I guess it's interesting because these studies all said in jurisdictions where it's legal, there's no adverse effects on vulnerable groups, and yet you have a study out of Belgium, not done by anti-euthanasia people, saying fits the description of a vulnerable patient group at risk of life ending without request. I think that the story should be closed now, that in fact there is a risk to certain groups without a question. So what's happening here? Yes, these are people who maybe the family was asking for, or there was some pressure because they weren't dying quickly, and the issue is somebody made a decision and did it. Okay? So here's another study out of Belgium again. Now what's good about these Belgium studies is they're done with total anonymity. So the doctors who received those 5-page questionnaires in that last study, they were told clearly, fill the information out with complete honesty, and there will be no ability to connect this to you, right? So please give us the information. So that's how they're able to get honest information, okay? So here's a nurses study, same thing. The nurses are given total anonymity. They sent out questionnaires to 1,678 nurses, 1,265 good responses, acceptable responses. So once again, there's a lot of data here. This is good data. These are good studies, okay? 248 nurses reported that the last patient in their care died by euthanasia, and almost half said that that patient died without explicit request. Now, this number isn't quite as accurate as the last one. There could be a number of issues on this one. Think about how the study was done. The last one, it's Alex died, and it's my doctor filling out the questionnaire, right? So it's about me. So it's about a person. This one is about nurses' experience with the last patient. There might have been two nurses dealing with the same patient. We don't know. It's possible these numbers are a bit off. Nonetheless, it's massive. But even what's more important is 14 of the cases the nurses admitted to injecting the patient, which is illegal. Now think about this. The point of the other side is we're going to legalize this with safeguards, and you're going to be fine. So don't worry about it. But you are imposing your morality upon us for saying that we shouldn't legalize. That's what they're going to say. You're imposing your morality. Well, let's look at this. The law says nurses can't do it. Nurses are doing it. Are there any prosecutions, any attempted prosecutions in Belgium? None. Zippo. Not one since the beginning. Not one attempted prosecution. Nothing. The law is simply not followed. People who died with euthanasia without explicit request, so this is the nurses study, they tended to be over the age of 80 and die in a hospital. Same patient group. Different study, different set of data, Same patient group. Very important. Very, very important. Oh, also right here. They said, it seems that the current law, which does not allow nurses to administer life-ending drugs, and a control system do not prevent nurses from administering life-ending drugs. It's pretty straightforward. This is the same data, but a different study. So this data, they looked at the 3,623 responses on the death studies in Belgium. They looked at the reporting. So the question is the law requires reporting. Now I'm going to ask you a question. Who does the reports? The doctor who does it does the report. So it's the same in Oregon. Doctor so-and-so prescribes a lethal dose. Person takes lethal dose. The doctor's usually not there in Oregon, are they? They're usually not at the death, but then they have to fill out a report. Do doctors self-report abuse? No. So are you going to find out any information from those reports that say there's problems with the law? No. And then the other side says, well, look at the reports. They're not showing any abuse. Everything's fine. You should feel safe. Anyway, in Belgium, only 52.8%, so that's of the 208 assisted deaths from that study, 52.8% were reported. The others were not reported. Very significant. Do we know that all reports are coming in Oregon? Well, actually, in the last report, it showed that a few didn't come in. Okay. What does it say? Well, often the doctor didn't think they were euthanasia deaths. Okay. So doctors in Belgium had this idea that if they use barbiturate and muscle relaxant, that's euthanasia. But if they give you a massive dose of analgesic to cause your death and you die from that, that's not euthanasia. But the law doesn't differentiate. The law says, did you intend to cause death, and did death occur? Because that's euthanasia, right? So this study says, well, a lot of times they didn't think it was, but in fact it was. So that's one issue. In fact, when I was talking to Bernheim, he said that there's a new paper that they've written that it's going to come out sometime soon. They're going to redefine euthanasia in Belgium to not include those cases. He says they're not the same. I said, well, they are the same. You're just using a different drug. Okay, so doctors consider the reporting procedure to be an administrative burden. Have you heard that before? Doctors thought it's a private matter between the physician and the patient. That's why they're not reporting. It's a private matter. Have you ever heard that before? It's between the woman and the doctor. They did not report the case because of possible legal consequences. And then there was a significant relation between reporting of euthanasia and the patient's age, with deaths of the patients aged 80 years or older reported significantly less often than deaths of younger patients. Same patient group, meaning the person is usually unconscious. The time of their death is not easy to project. No one's asked for euthanasia. They are euthanized. It's not reported, often done by nurses. And because it's never reported, guess what? It's a silent crime. It's a silent crime. I'll say one other thing. Where does the other side get their stats when they say that there's no problem with this, there's no fear of a slippery slope? Where are they getting all their stats from? Because they do always have studies. Where do they get their stats from? They get it from the official reported numbers. And the official reported numbers, as I say, usually look pretty good because doctors tend not to self-report abuse. And then they also, this Belgium study looked at a similar study that had been done in the Netherlands in 2004, and it showed that doctors who don't report never intended to report. And they said, well, in fact, our stats show the same thing in Belgium. Doctors tend not to, if they didn't report, they probably never intended to. And then it goes on further, it says, this is their study. It wasn't me writing this. None of the stuff I've written, I'm just quoting it, word for word actually. It says, legislation alone does not seem sufficient to reach the goal of transparency. Total or 100% transparency seems to be a rather utopian ideal. So they're going to say to you, we're going to legalize euthanasia or assisted suicide. In California, they're going to be talking about assisted suicide. And you're going to impose your morality on us by saying we shouldn't do it. It's your problem. We want this, but we will protect you with the safeguards. You know what your response is? I don't live in a utopia. This is not a utopia. There will be deaths without request. There will be people being pressured. These things will happen. Abuse will occur. Guess what? The last I noticed, everybody in this room, we're all human. Abuse will occur. It already is happening. You're right. And actually, they use that example against us. They say, oh, well, it's already occurring, therefore we should legalize it and regulate it. Okay? So they got you coming and going. This just shows you the Netherlands numbers. And what's important about this is the 2012, when the study came out about the 5-year Netherlands numbers, the Lancet, in their conclusion, said that the rates of euthanasia have remained stable. So if you read the conclusion from the Lancet, it says rates of euthanasia have remained stable. So what it is because euthanasia is going out of control, they want to hide it by saying to you that it's stable. And so when you saw a lot of the news articles about this study, a lot of the news articles said rates of euthanasia remaining stable. Even though that was a lie, because you look at the numbers, in 2006 there was 1,923 reported euthanasia deaths, 23% underreporting in 2010, 20% underreporting in 2005. And then, of course, 2010, that's 3,136 reported euthanasia. Well, that's not stable. Last year, 4,088. And remember, when you add the unreported numbers in, that puts it over 5,000. It's just growing and growing and expanding. So when examining these studies, I tell you that not all is good in Belgium. And yet, they're going to be talking about legalizing assisted suicide here. So what is the difference between assisted suicide and euthanasia again? The difference is how we do it. But the fact of it is that in the end, it results in the same thing. So let's look at the question of depression. Depression is a primary risk factor for euthanasia. But this is a great study, and I always use the Van der Lee study because Dr. Van der Lee was pro-euthanasia in the Netherlands, and her hypothesis was that in other studies dealing with depression and requests for euthanasia and assisted suicide, that in fact they were false studies because they were done in countries where it was illegal. So she says in the Netherlands, these decisions are well considered and not because of depression, is what her premise was. But what does she actually find? She finds in her study that to our surprise, we found that a depressed mood was associated with more requests. But it wasn't just more requests. It was 4 times greater risk of requesting euthanasia when they had signs of depression or feelings of extreme hopelessness, as she defined it as. And then she concludes that depression is a primary risk factor for requests for euthanasia and assisted suicide. So here's the point. That doesn't mean that nobody who's not depressed are ever asking for it. It means that people who are depressed are very likely to ask for it. Okay? And this is important when you consider the stats in Oregon. Okay? So the similar study done by Linda Ganzini looked at 58 people who asked for assisted suicide. And out of the 58, 15, because they were part of her study, she was able to assess them. She defined them as either depressed or experiencing strong feelings or extreme feelings of hopelessness. That's a very high rate of 26%. Now that shouldn't surprise you, because if you had a terminal condition, you might also feel very depressed or have feelings of hopelessness. So that's a normal human condition. The point of it is the Death with Dignity Act in Oregon requires that depressed people be sent for an assessment. That's supposed to be a safeguard. Supposed to be a safeguard. It's not a safeguard. In 2007, which was the year the study had been done by Ganzini, 49 people were reported to have died by assisted suicide in Oregon, and none of them were offered a psychiatric assessment, even though this study showed 15 of 58 people who requested it should have been sent for an assessment. At least 15 of the 58. So we go on further. Now these stats are a year old, but in 2011 there were 71 reported cases of assisted suicide. Only 1 was referred for a psychiatric assessment. In 2009 there was 59 reported cases. None of them were referred. And in fact, the issue of depression is not being looked at clearly in the state of Oregon. Because if you look at it further, why is that a case? Well, in 2009, Compassion and Choices. Now, Compassion and Choices, we have to admit, is a good name. That's a very good name. Now, how much time do I have left, Bob? 10 minutes. So we're in very good shape then. We're in very good shape. Compassion and Choices is actually a good name. I have to admit that that's a good name. That's good semantics. Okay? They admitted in their report from 2009 that of the 59 assisted suicides, they had done 57. So what it means is that if they set up here in California, their affiliate will become the doer, right? They're the ones who are doing the referrals. They're the ones who are doing it, meaning you're not going to be protected by the law, even if there are supposed protections. Will the physician self-report abuse? This is an important question. Reporting is done after the fact. Do you know how they died? So what happens is in Oregon, the same thing would be the same thing in California, because it's also in Washington State. The person receives a lethal dose. After that, there's no further looking at the question anymore. They have it. The only other time anything is done is after they are dead, the report goes in. Okay? So the question is if that person died, do you know they actually died of assisted suicide? You can't prove it. There's no proof. There's no oversight. There's no mechanism in Oregon to ensure that all assisted suicide deaths are reported. Anyway, this just shows you the studies in Belgium and the whole thing. Basically, what we know is there's great abuse going on there. And here are some keys to winning the battle. I could talk a lot longer if I wanted to, but I was only given an hour. We should focus on the likely victims. That's what makes us very successful. So the thing of it is having spokespeople who are people with disabilities. So in Massachusetts, for instance, when the referendum was defeated by 51 to 49, now a lot of people say to me 51 to 49 was too close. I say no, 49 to 51 would have been a problem. 51 to 41 was a good victory. John Kelly from Second Thoughts, who's now working for Not Dead Yet. John Kelly is a quadriplegic and is a fabulous spokesperson. And so there's lots of reasons why we won in Massachusetts, because if you win 51 to 49, there's lots of small factors. In fact, one of the key organizers of the campaign made it clear there was no one thing that led to the victory. There was a multiple portion of different things that occurred that led to the victory. I would think that John Kelly was a key, because when they kept on trotting out their people who were suffering, John Kelly was suffering more than all of them. And yet he was clear, he was convincing, he was articulate, and he was opposed. And he was very liberal. Right? That was very important too. You can't have people from one side of a political spectrum or one side of an issue who are leaders of the whole thing. It can't be like that. Focus on elder abuse. Why? Well, when mom goes in and asks for assisted suicide and good son is sitting beside her, is she actually wanting assisted suicide? No. That's exactly it. You don't know. We actually don't know is the point. She might be. She might not be. We don't know. What we do know is that elder abuse is a common problem, a growing problem, and what we do know is a lot of people go through subtle abuse throughout their elderly existence. Choice is an illusion, especially in this context of abuse. Even here, they're going to sell it to you as choice. Choice is a false concept here. It's about somebody else being involved in my death, and the law is a protection. It is not taking away anybody's rights. Working with all people from all points of view. There are people on the Euthanasia Prevention Coalition board who are not pro-life. That is a good thing. Why? Because we're not speaking to one group of people at all times. We're speaking to people from all points of view. So in Canada, we defeated a euthanasia bill in 2010 by a vote of 228 to 59. Substantial, massive, 228 to 59. And that's why, of course, Quebec came next, because they decided, well, if they're not going to legalize this federally, let's try and do it in Quebec, right? Or Quebec. Anyway, the fact is that we had all-party opposition to this, because we had people from all points of view visiting their members of parliament. We have to be clear. The other side wants you to be confused. They want you to be confused. We have to be clear. And that's very important. So when we're talking about medical treatment issues, are these things being abused? That's what we're here to talk about today, and the answer is yes. Abuse is going on. By legalizing, we're not going to stop the abuse. So let's look at this clearly. In Quebec, so that's like the American Medical Association, the Canadian Medical Association opposes euthanasia and assisted suicide. But the Quebec Medical Association is in favor. So what did they argue? They said, in Quebec, we're doing it already. And that's what they're going to say. And so therefore, we need to legalize this and regulate it. What they're actually saying is, we know abuse is occurring, and we're doing this already. We're killing people already, and abuse of the law is occurring. We need to protect our doctors. That's what they're actually saying. Okay? So then when you go through, I got this pamphlet here at the back. When you go outside. It deals in the Canadian context, but all the arguments are the same no matter where you are. And I go through it. I say, well, what are you talking about? Because the proper use of analgesics is not euthanasia. We're not looking to have people suffer. So using analgesics in large doses when someone's suffering great pain is not euthanasia. So if you're intending to cause death with it, it's an abuse of the use. Are doctors who are abusing the use going to stop abusing after it's legal? No. Do all doctors abuse? No. Most don't actually. Some do. Some think it's in your best interest. Some are very paternalistic. They like to think of themselves as very liberal and open-minded. They're very paternalistic because they think your death is worthy of their decision. And we'll go to question and answer. There must be a couple. Yes?
So, if we're trying to protect our loved ones, and the doctor has written out the death certificate, and he's protected, can we have a coroner examine the patient, have an autopsy?
Okay, so when there's a suspicious death, yeah, when there's a suspicious death, so here's the difficulty here, as everybody's leaving the room. It must have been the question. I don't know. Okay, so here's the situation. You have a very difficult time because as an individual, you have to get the medication reports, and only the person who is like the power of attorney or the closest next of kin, in the case of your spouse, they have the right to. Now, often in these cases, someone is very shocked. They didn't expect something to have happened. They were in a hospital. It's a difficult situation as it is. And so now what we're saying is you should probably, in a suspicious case, ask for an autopsy. Often it's not done. And then you have to get these medication reports and everything else. And often if there's an intentional overdose, even though the medication reports are often electronic, there was a case in Toronto of a clear intentional killing. And in the end, the parents went through the courts. They did everything they could, and they couldn't prove it. And it's incredibly expensive. So we're finding the problem in Canada is the same problem you'll have. The hospitals have this huge amount of financial resources, and they always hire the same law firms.
They circle the wagons, and they protect their physicians.
Yeah, but even more than that, they have professionals who organize these cases, who are experts at it, who are given good pay to do it, and then you've got some really caring family who are now having to defend their right to find out what happened to their family member. It's a loaded case. It's very difficult, but you have to ask for an autopsy. Remember, the person who has the right to it is usually the spouse or the power of attorney, and only that person. And it's a serious problem because how do you protect yourself? It's a serious problem. I think that hand was first, then I'll go here. Yes?
I'm an attorney and I represent children with disabilities
Yes.
against corrupt government in California, and it's their civil rights and constitutional rights, and it's a lot of litigation. But what I've started doing, I've been fighting the corrupt agencies that systematically deny access to services. But what recently I did was, instead of suing the governmental agency, I sued the doctors who are involved with it for medical malpractice.
Right.
And what I think what you could do is, especially when you're in a situation where you have somebody in the hospital, is just give notice to everybody that's caring for your loved one that I have an attorney who specializes in euthanasia, and we will be going, just give them an upfront notice. That the nurses, because you can sue nurses for medical malpractice as well. And so maybe that's kind of an easier way. I mean, obviously the legal battles need to be fought, and the more that we
Yes.
will file, the better. But if you kind of give them an upfront notice.
Okay, so I think that you're a great resource, but there is...
No, I'm not asking for anybody to, I have enough work to do.
She's suggesting that she's a lawyer, and the better idea is if there's been an abuse case that has resulted in the intentional death of a loved one, and she represents children with disabilities and families of children with disabilities,
Pro bono, I cannot handle any.
that she's saying the best thing to do is actually sue the doctor and not sue the institution, because you're suing the institution, you're getting into real problem. Now you should email me at info@epcc.ca. You should all email me at info@epcc.ca. I've been given 1 minute, so I'm going to take your question, but quickly.
Real quick, are you aware of any successful wrongful death cases brought in connection with any of these euthanasia issues that you brought up?
No. Very easy answer. So you guys should all be emailing. You should be going to my blog, alexschadenberg.blogspot.com, and keep up to date. The other important thing about emailing me is you should be on our email lists, and you should be aware, because whenever there's something going on, we send out an email about it, and you have to be knowledgeable about what's going on before you can react. Okay? So, and I have a table back there. I'm happy to talk to you, and thank you very much.